Hello, everybody, and welcome to the Movement Impairment Syndrome Foundational Lecture on Lumbar Spine. I'd like to apologize to our Optum participants as we were intending to present this lecture at the last module. However, we ran out of time just focusing more on some of the other material. We'd like to also welcome our student physical therapist followers and anyone else that wants to view these. Just so they can kind of get a sample of what we're trying to teach here at Optum Manual Therapy. Now, with our Optum participants, if you have any questions about this lecture afterwards, feel free to contact myself, Dana, or Jim, or you can just wait until the next class and bring up some questions. We're going to be talking about the hip aspects of the movement impairment syndrome as well. So movement impairment syndromes was started by Shirley Sarman. It is a labeling a condition is most often the first step in treatment. Referral sources should expect a label from us, yet currently physicians refer to consultants for diagnosis. They refer to PTs for treatment. Autonomy will be actualized when physicians refer to PTs to obtain diagnoses. So what she's trying to say there is that we need to create these diagnostic categories as physical therapists so that there's a better communication between the physicians and ourselves, and between the physical therapists as well. So, patient going from one clinic to another knows exactly what's going on, and there's a better continuity of care. So some of the general concepts is what we're going to start with. Normal movement requires ideal alignment to occur. So proper posture is going to play a big role with movement impairment syndromes. And as you likely have seen as a physical therapist thus far, our population does not like proper posture. So there's going to be a big educational component with that as far as trying to get people to at least move towards the norm with that. With sustained postures and repeated movements throughout each day, we are at risk for developing deficits in flexibility, strength, and movement. Due to the imbalances in strength and flexibility, the passive tension in our muscles can alter how we move. So I wrote this example down here at the bottom, and this can extend to any other joint or any position, as creative as your mind can be. So if we're sitting in a sustained position, eventually we're going to divide some tight hip flexors and lengthen lumbar extensors, right? Because you're going to sit in that slouched position. Right? And our hips are going to spend more time in flexion than in neutral or extension. So when the patient tries to complete any extension motion, for example, pre-swing and gait or initial swing, motion will preferably come from the spine because the hip will have developed increased passive tension. Now, how that occurs is that by being in that shortened position, the muscle develops an increase in stiffness there, so that when you start to move into the extension motion, whether it be hip or lumbar, the motion will preferably have to come from the lumbar because the hip is more stiff. And we'll get into more detail of that in the next few slides. The abnormal movement patterns lead to repetitive microtrauma and then pain and decreased function. All right. Repetitive use or excessive load exceeds tissue's ability to withstand injury. So if you think about Wolff's Law, I don't know if you remember that concept right there, but stimulating a bone by whether it's a muscle pulling on it or it's a force going through it, that is what actually causes more bone formation to occur. So when we're having these abnormal movement patterns, because we're not in ideal alignment, it changes the normal arthrokinematics at the joint. And by doing that, you're getting increased contact on certain aspects of the bone and other tissues as well that otherwise wouldn't be there. And that's how you develop like these bone spurs and other degenerative type conditions, is it just stimulates and stimulates and stimulates the abnormal growth. So affected regions actually begin with relative hypermobility. And we call that the direction of susceptible motion. But with repetitive microtrauma, degenerative conditions develop, leading to pain and hypomobility. So going back to our example with the lumbar spine and hip, is say the lumbar spine becomes more hypermobile compared to the hip. And so each, throughout your life, you're bending forward, walking, whatever. And the lumbar spine is moving in increased amount and in the abnormal way compared to normal, that you develop this, what we call relative hypermobility. So it's moving more than it should. But over time, because those patterns are abnormal, it causes a repetitive microtrauma, like I was saying with Wolff's Law, and it actually leads to degenerative conditions like degenerative joint disease, degenerative disc disease, bone spurs, osteophytes, and that is what, in this model, causes pain and leads to hypermobility. Now, in general, we're going to say these things are caused by repeated movements and prolonged postures. All right, we'll abbreviate that RMPPs there. Now, abnormal and painful movement patterns, this is where our diagnostic category goes to, classified into movement impairment syndromes, or we'll also abbreviate that to MIS. Now, this is the cause of the cause, and this is why it's so important. If we go back to the pathoanatomical model, you're going to say like, oh, maybe the pain is being caused because this bone spur on L3 is pushing down on the nerve below. That's why the patient's having pain. But why is it that bone spur or that pinching is occurring at all? It's because of how the patient is moving. And we'll demonstrate that later on as we get into the description of like the treatment and actual examination process. So going back to repeated movements and prolonged posture, muscles and joints actually respond to what we do throughout our daily routine. So it's really important that we find out exactly what our patients are doing throughout their day so we can determine what the cause is of these imbalances. So any deviation from normal will create muscular imbalances. And that's where we get our RMPPs from. So as far as prolonged posture goes, maybe your patient is sleeping turned onto one side with their top hip in flexion, internal rotation, and adduction, and that's placing an increased strain on some of the posterior hip structures or the lumbar spine. Maybe it's just how they're sitting or the fact that they're sitting all day. Stuff like that is what you want to kind of keep in mind, is just what they're regularly, what kind of position they're regularly assuming. Now, repeated motions is probably going to be harder to pick up, actually. The patient might give you a hint that they're doing this activity, but you need to actually examine it and see what the deviation is. So maybe when they're reaching overhead regularly throughout the day, their cervical spine is extending each time that they do that. Or maybe when they're turning to one direction, if they're sitting in a chair, the motion is primarily coming from the lumbar spine and not the hips at all. As we get to the different body parts in our future courses, we'll go over those other examples, but today we're going to focus more on lumbar spine. So motion takes the path of least resistance. This is probably one of the most crucial concepts as far as understanding movement impairment syndromes. So Sireman likes to use the example of having a couple springs hooked together, one of which has an increased stiffness relative to the other. And so when you try and separate the two, you're going to see the one that has less stiffness in it actually exhibit most of the movement. All right. And so that translates directly to our body as well. Say it's the hip and the lumbar spine instead. So the lumbar spine being the one with less resistance and the hip being the one with more. So when you try and move one direction, motion will preferably come from the lumbar spine. Okay? And this can apply either direction, other body parts as well. I mean, that's just the pattern, is that the lumbar spine becomes relatively hypermobile. So that goes into our next concept here, relative flexibility versus relative stiffness. All right. And so what that means is that when we're looking at, again, let's go to the lumbar spine and hip. Maybe it's the hip flexor and the abdominal musculature. What tends to be the trend is that the hip flexor exhibits increased stiffness, and the abdominal musculature is actually weaker and exhibits increased flexibility. So when the person is moving into extension, the hip will be the more stiff spring, like we were saying before, and the abdominals will be the less stiff spring. So you're going to see most of the motion coming from the lumbar spine. All right. And so it's not necessarily a true adaptively shortened flexibility deficit. And we'll get into that. It's a increase in passive tension. All right. And the third principle I want to go over is that movement impairment syndromes does not require pathoanatomical diagnosis. All right. There's a reason for this. With what we're learning in pain science lectures, is that our pain is actually becomes increased just by focusing on these pathoanatomical diagnoses. If you tell a patient that they have L3-4 radiculopathy because this disc is pinching down on this nerve, the patient's going to get overly focused on that, and they won't understand how conservative management can actually easily alleviate the symptoms. Most difficult patients to treat in my mind are the ones that are too focused or have their MRI findings memorized and won't let go of that. You know, they question each motion like, well, aren't I pinching on, crushing down on this nerve? So, and the other component of why this is important is because those things don't just happen for no reason. Based on this model, the pathoanatomical findings occur because of abnormal movement patterns. And we want to find what those abnormal movement patterns are and correct them. And you can see these pictures here, just especially this bottom one, what is a more normal squat versus probably what we see more commonly. And that's because in that hip there, it's relatively stiff, and in the lumbar spine, it's relatively flexible. So as the person moves into a deep squat, they have what's some people will call like the butt wink movement, where they are unable to maintain that anterior pelvic tilt. And then here's a little guy who, of course, can do the deep squat perfectly. All right, so this is a good picture talking about relative flexibility and stiffness. So here, the top picture, we're going to show as the patient is in prone and they move into knee flexion, all things being equal, the motion will come from the actual rec fem or quad muscles, and nothing occurring in the lumbar spine, because the lumbar spine has more stiffness than the quad and rec fem muscles. Now, moving into the second picture here, the lumbar spine is going to be not flexible as well, but the muscle here is going to be actually adaptively shortened, and this is going to be the difference between adaptive shortness and stiffness. As you bring the muscle into flexion, you will not be able to go any further, even if you try and block right here at the lumbar spine, because there is no more room in the muscle. It is like a contracture, basically. And this is the bottom one here is what we're going to see the most commonly. When your patient is in prone, they might even be resting in prone in a little bit of hip flexion, but the lumbar spine will be more flexible than your hip and thigh muscles here. So as you move the knee into flexion, the stiff muscles here will then prefer not to move, and the superior attachment at the innominate will cause lumbar extension instead. So what you'll see is the patient, while you're flexing the knee, the patient will kind of move into a bit of hip flexion and lumbar extension on that side, whether it's active or passive. And it's just because those muscles in the hip and thigh are more stiff. Now, if you were to stabilize this and then try the same thing, you would actually be able to cause full movement. But without stabilization, that's the normal movement that occurs because the lumbar spine is more flexible relative to these muscles here. Now, stretch weakness versus stiff muscles. Stretch weaknesses and altered starting positions due to poor posture all create asymmetrical length tension relationships that then alter the normal arthrokinematics and the related joint and eventually produce pain. This is a tough concept to understand simply because a lot of times PTs just like to stretch certain muscles that they think are tight, and they think that if you stretch something and it feels tight, then it is tight and needs to be stretched. However, if you stretch any muscle, I mean, it can be completely over lengthened enough, you will feel some tension and stretching in it, and the patient will report that. And stretching feels good a lot of times, so people say they want to do it, even if it's counterintuitive. All right, so overstretched weakness due to prolonged positioning is a common occurrence. All right, so think about if you examine someone's scapula, typically the pattern that I see for any upper quarter dysfunction is that the scapula is in downward rotation and depression. And what that means is that the upper trap is actually in a lengthened position. And so you stretching that is actually going to increase the duration of their symptoms simply because you're not helping that muscle shorten at all. And so what is occurring is that the muscle actually has an increased resting length, and it will test weak pretty much everywhere. Now, the upper trap is a bad example because you have substitution through the levator scapula as well. So it's hard to truly cause a break in that test. Maybe if you get some of the cervical motion involved with the manual muscle test as well, you'll get it. But a better example is probably the glutes. So with how much time we're sitting in flexion, or people in an anterior pelvic tilt, the glutes are constantly in a lengthened position. And so typically for our patients with low back pain, especially the ones sitting all day, have pretty weak glute muscles. And again, that can be tough to truly isolate because they might test strong for hamstrings when trying to do your glute test, and you just need to do a test to figure out what is their preferable muscle contraction, whether it's hamstring or glute max. So overstretched weak muscles play a significant role in poor muscle recruitment and muscular imbalance and eventual microtrauma. So going back to our scapular example, so let's say the upper trap is lengthened and weak. So the scapula is sitting in a depressed and downwardly rotated position. Now we know when you raise your arm overhead that you're supposed to have a sufficient amount of upper rotation and elevation of the scapula. Well, because that muscle is weak, you're trying to get levator scap compensations, you might elevate the scapula, but you're only going to encourage downward rotation, which can cause some impingement in the shoulder. All right. So what we need to do is actually facilitate the upper trap and improve its function, not necessarily stretch it. Now, stiff muscles, the muscle will appear spastic and tight, but stretching won't change much until the repetitive movement and prolonged positioning is corrected. Now, we want to support these muscles that are overstretched and weak. So for the upper trap, we don't necessarily want to be stretching it the whole time. Instead, for example, say throughout the day their arms are hanging by their side and they're typing in a computer, and that's the reason why the scapula prefer that position, because that just pulls the shoulder blade down into downward rotation and depression. So you can strengthen the muscle all you want, but odds are it's going to have that preferred position just because they're in it throughout their day. What you need to do is that throughout their day, as much as possible, get their scapula at least a little bit out of that depressed and downwardly rotated position. So that can mean making sure they're using armrests that actually support the shoulder, and the patient doesn't have to reach down to the shoulder. Maybe it's that when they're walking, they have to cross their arms. And you can actually examine this by having your patient, this could be any upper quarter symptoms, so neck, thoracic spine, shoulder, have them do whatever motion is uncomfortable with their neck or shoulder. And then if you either support the scapula or the shoulder girdle by providing a little passive elevation, and then have them repeat the neck movement, or maybe if it's the shoulder blade, you actually facilitate the upward rotation. And they actually feel better with taking that depressing tension off of it, that's a good sign that that would be beneficial. So when it comes to testing in the Saarman method, what you want to do is have them perform a specific motion. We're going to have the motions listed out for each movement impairment syndrome of the lumbar spine. Look for pain provocation and movement from joints that should not be moving. For example, during the bent knee fallout, you should just have motion of the hip, but what you'll see a lot of times is the pelvic girdle and lumbar spine moving as well, and a report of pain. And what you're going to do is you're going to cluster these different findings to tell you a direction of susceptible motion. All right, so one test doesn't exactly mean one diagnosis, and that's because the same test might fall into a couple categories, but as you group your different positive tests together, that is what leads you down one path versus the other. To diagnose a direction of susceptible motion, what you want to do is once you've had the patient perform that painful and abnormal movement, you want to stabilize the affected region and have the patient repeat the motion. So basically, you're eliminating motion from the abnormal joint, and what you should have is an elimination or at least a reduction of pain. So in the lumbar spine, there are 5 movement impairment syndromes: rotation extension, extension, rotation, rotation flexion, and flexion. I believe these are in the order that Saarman lists as most common prevalence. All right, so lumbar rotation extension syndrome. So pain will typically be one-sided or an increase of symptoms on one side, and the symptoms will increase with extension or any rotation of the lumbar spine to that side. So associated diagnoses, so if this is back to the pathoanatomical approach, you may diagnose it as facet syndrome, spinal stenosis, spinal listhesis, spinal instability, degenerative disc disease, lumbar spine, osteoarthritis, and then disc herniation. Some of the associated signs you may come across are the patient may present with a history of activities that required repeated lumbar extension rotation. So maybe it's like golf, tennis, something like that. They might rotate their trunk and not the entire body while sitting repeatedly throughout the day. They'll have difficulty dissociating lumbar extension rotation from other body movements. They'll have a habit of sitting with one foot or on one foot or crossing their legs, and you'll probably find an asymmetrical IT band length or a leg length discrepancy. So we're going to go through all the tests in each position and all the findings you'll probably have as required for diagnosing each movement impairment syndrome. Now, the way that I, excuse me, the way that I have this laid out throughout the lecture is that I'll have some videos for these tests in each section, but there's definitely a crossover, like supine bent knee fallout might be in 3 of the different actual movement impairment syndromes, but I only have the video or picture in 1. So if you see it as I'm going through it and you're not certain what I'm talking about, it should show up later, and it's the exact same thing that you'll see and present with for the different body parts that it's in. So some of the key tests in standing for lumbar rotation extension syndrome, you'll probably notice that there's a paraspinal asymmetry, which can either be a hypertonic muscle on one side, the irritated side, or it might be that the lumbar vertebra is slightly rotated to that side. There's probably asymmetrical mobility and pain with side bending and rotation of the trunk. So you're going to have pain and limitation towards the involved side with rotation. And then with side bending, the reason why side bending is a limitation is because the way Sauerman presents this is that the coupling in the lumbar spine is contralateral. Even though Fryette's laws are very inconclusive, we're going to go that route as far as this lecture goes. So typically you'll actually see like a hinge point almost as they bend to the side, that the motion stops coming from the lumbar spine there. The patient will have increased symptoms returning from flexion, and that's because they'll prefer to extend from the lumbar spine first, when in reality the motion should be coming from the hip first and then kind of equal from lumbar and hip. They'll have pain relief with forward flexion, or at least a back flattening on the wall, like they're getting some support. Lumbar extension will be painful for them. You may notice a hinge point there as well. And then if the patient performs single limb stance, you may see a pelvic drop or a rotation of lumbar spine and pelvis as they're trying to perform that. And as you can see here, I mean, this is like your Trendelenburg test, pelvic drop, and then there's a little bit of rotation posteriorly as well. So I've taken some videos for these different tests throughout this lecture. Some of them are better than others, as I really tried to exaggerate the motions. Other ones, I had a hard time really trying to perform them poorly, but I gave it a shot. So as you'll see here first, it's going to be the wrong way, leading with the lumbar, even the thoracic spine, and then trying to perform it first. You see the pelvis tried to shift forward there first. So I'll play that again. So leading with the lumbar spine, and then the pelvis shifts forward, and then the more proper way, the pelvis tries to shift immediately. And I even had a little pause there, trying to show the two different phases of it, but hopefully that depicts it well enough. And what you'll have your patient do is perform the corrected version, and you'll probably have a decrease in pain if they do it that way. So lumbar rotation extension syndrome. Some of the key tests and signs in supine. So if the patient is laying in supine with their legs extended, typically that will be pretty painful for them. And the reason being is that the tight or restricted hip flexors are causing the discomfort and actually an extension motion of the lumbar spine, which is painful to that patient. Now, during a bent knee fallout to the involved side, you'll notice an increase in pelvic rotation immediately, and a cause of pain probably as well. And typically it's during the initial 50% of the lower extremity movement that you'll see the lumbar spine rotating. During marching, so this one down here, pelvic hip flexion, hip and knee flexion, that's basically marching. You'll notice that the pelvis is trying to rotate as well and may produce some pain. During your Thomas test, what you'll see is that immediately your patient will want to kind of go into like a lumbar extension or anterior pelvic tilt as you're going through the Thomas test. And it's more so that it's, again, stiffness and not necessarily a true tightness. Okay, so stretching this won't necessarily help because when it comes to passive tensile structures, we don't necessarily want to stretch those. We want to try and stabilize the hypermobile area. And then a passive straight leg raise pain can be eliminated with complete relaxation. I know that sounds odd, but if you have your patient perform a passive straight leg raise, odds are there's still going to be some guarding there and they're going to report some pain. But if you say like, hey, like let your leg fall down, I've got it here, and then they relax a little bit more, And if their pain goes away, that helps to confirm this. And then with shoulder flexion in supine, you'll probably notice some lumbar extension just due to the attachments from the latissimus dorsi. So the motion is going to prefer to move into extension lumbar spine as opposed to flexion. And if you're trying to stress that flexion motion, lumbar spine is going to extend as well. All right, so here's bent knee fallout, and I think it starts right away. But you're going to see immediately, notice how the whole pelvis is moving. That's the wrong way. And then the proper way, so some stabilizing there in the pelvis, and the motion was just coming from the hip. And the Thomas test, this was not the best representation of it. So as the leg drops down into extension here, watch this area here. See how right there it's starting to extend in the lumbar spine? All right. And then as you move the hip down into extension with stabilization, you should get full motion into extension. This one actually was a little bit limited passively, but I think it contributed to some of the stiffness as well as to why we saw extension there. But typically what you'll see is that muscle is actually full when you stabilize it there, so it's not a truly shortened muscle. It's just that as they move into extension of the hip, the stiffness is in the hip and there's increase in flexibility in the lumbar spine. Now in sideline, the position by itself might be painful, and that's because you get some sort of shear to one side in the lumbar spine. Could be because it's creating like a relative side bend, which thus creates a relative rotation. But you can often decrease those symptoms just by putting a towel under the waist. If you have the patient doing a clamshell, what you'll notice is that just as when you're doing your exercise, they like to kind of compensate and get the motion from the lumbar spine as well, whether it be weakness or direction of susceptible motion, may create pain. But if you stabilize in the whole pelvis and lumbar spine and they have to just do the motion in the hip, the pain typically goes away. And it gets to be a harder exercise as well. With hip adduction, you'll see that the pelvis drops and they move into like a side bend, contralateral side bend almost. And hip abduction, you might see some like hip hiking and cause some pain. So here's your clamshells. So as you can see, again, whole lumbar spine and pelvis is moving, and in the proper way, stabilization there, and the motion just coming from the hip. First one will be painful, the second one will not, or at least will limit the pain. So in prone now, you're going to have the patient perform just hip rotation, and it's kind of similar to bent knee fallout, where early in the motion, you're going to see lumbar and pelvic rotation. All right, and if you stabilize that and get just pure hip, pain should go away. You might also see an asymmetrical amount of lateral rotation or extension of the lumbar spine during hip extension. So as the patient just actively moves into hip extension, you'll see one side of the lower trunk or the pelvis just kind of raise off the table, and the other side might not at all. And again, isolate that. So block the lumbar spine, have the patient do it again. Probably the pain will go away. Now, if you have the patient do, this is from that picture we had earlier, just knee flexion, you'll probably see the lumbar spine or the hip move into flexion, the lumbar spine, a little bit of rotation or extension. We want to block that and isolate the motion. Now, sitting should decrease their symptoms. However, if they're sitting on the edge of the chair routinely, that may cause pain, and the reason why is because they're using their hip flexors to maintain that erect position, and they may just say it's painful. So if you actually educate them on using a backrest, their pain will go away typically. You might also notice that as they extend their knee, on the symptomatic side, that some lumbar rotation will occur as well, which can cause some discomfort. So we want to isolate that and have them repeat the test. So here's that prone knee flexion. Again, this is really exaggerated. You won't typically see it that bad. I mean, I have seen it that bad. There you go. But you'll see some version of that. And here's your hip rotation. Oh, went too far. There you go. And this works for hip internal or external rotation. Not sure why I chose internal. All right, now when you get the patient in quadruped, typically that position is just, it takes away some of their discomfort because the lumbar spine is no longer in a loaded position. All right. Now, if you have the patient perform a quad rock back, what you may see is that the spine rotates from one side to the other, and this can be due to either a hip mobility restriction, like a true adaptively shortened muscle, or it can be from just stiffness. We may need to tell the patient to actually push through their arms so that they relax their hip flexors and cause an improvement of the motion, and it might cause a decrease in the pain. With rocking forward, because they're extending their hip and spine, you're probably going to have some pain with that. So if you isolate the motion to just the hip, it should go away. With the quad rock back, the symptoms may go away, but you may note that rotation. And then in quadruped, if you have the patient perform shoulder flexion, you may see some lumbar rotation as well. So weird angle, but you are able to see a slight lumbar rotation with this rocking back motion here. So really try and watch the lumbar paraspinals here, and it'll be on the right side. There we go. So really watch, like right here. So it's very slight, but you can see that it really rotates there. Now in your most of your patients, you'll probably see an exaggeration of this. You're able to see it better there at the end. Let me play that one more time. During the exercise of quad rock back, you may see it even more. One more. Right here. All right. Now during gait, you'll typically see that during the end of the stance phase to toe off, that their lumbar spine will prefer to have the rotation, or your body will prefer that the motion comes from your lumbar spine and pelvis as opposed to pure hip extension. All right. Sarman likes to describe it as the tail wagging the dog type of thing. And you just see that their hips are causing way more rotation than it should occur. And if you have the patient control, like activate their TA and then put their hands on their hips to monitor the motion, that it should go away. Now, I took a video here. This is me trying to really exaggerate it. I still don't think it's that obvious, but I'm going to try and point it out for you. So really watch my left side right here. I mean, obviously you can see a little bit of a pelvic drop there. But there's an increase in motion going on right here relative to that. And then you're going to notice the difference when I put my hands on my hips. Now there's not quite as much motion. All right. So now we're switching to lumbar extension syndrome. And like I said, a lot of the tests will kind of carry over, and I'll just mention them. but you will see the same finding if it's in the same category, okay? So lumbar extension syndrome, symptoms are typically present or increased with positions or movements into extension. They're decreased or absent when moving into flexion. All right. The associated diagnosis may be spinal stenosis, degenerative disc disease, spondylolisthesis, herniated disc, and osteoarthritis of the lumbar spine. Some associated signs that you'll see is that the patient may present with a lumbar lordosis, an increased lumbar lordosis, I should say. They may have decreased lumbar flexion range of motion. Hip flexion flexibility is greater than lumbar spine. Think more so of your dancers, potentially, or gymnasts. You may note an anterior pelvic tilt and an increased lumbar extension and pain with prone knee flexion. We'll get to that. And you may find some short hip flexors and lumbar paraspinals. May note some obesity with a large abdomen or large buttocks. So in standing, again, you might know back extensor hypertrophy, but it might be symmetrical or bilateral. These tend to be that younger individuals often have marked lumbar stenosis, while older individuals, or excuse me, I think I should say lumbar lordosis, while older individuals have a flat lumbar spine with spinal stenosis. So they might start out with the lordosis, but as they get older, it appears or presents that the lumbar spine is flat. When returning from flexion, they will lead with lumbar extension, which is typically painful, or shifting the hips anteriorly and thorax posteriorly. Again, if you correct the form with it, introducing hip motion first, then their symptoms should at least decrease. Their symptoms do decrease with flexion. And, excuse me, they may note an increase in symptoms if the patient leads with the hips when returning from flexion, as we said before. So another way to do that is to have them move kind of towards like a table or something and have them start in flexion and use their hands to kind of facilitate moving into extension so they don't have to use the lumbar spine as much, and you'll probably notice a decrease. Now, when you have them in prone, the position by itself might cause increased symptoms, because if you think about it, prone kind of pushes the hip into extension, the lumbar spine into extension. If you have the patient perform hip extension, you may note that the lumbar spine extends preferably. Again, motion takes the path of least resistance. So if you stabilize that, move into extension, symptoms should go away. If they perform knee flexion, you'll see the same results as that previous example, where the lumbar spine extends, it rotates, and the hip moves into flexion. When sitting, they'll probably present sitting in lumbar extension. So if you move them into a slight bit of flexion or even into neutral, use that back support, symptoms will probably go away. So here's a picture of improper and proper hip extension. So this is a positive test where you're seeing the lumbar spine and pelvis truly try and facilitate moving into extension. And then here's where you're trying to keep that neutral, and it's pure hip. All right. Again, I really tried to exaggerate this so you can see it. So you probably won't see this extreme, but you will see this type of motion. Now in supine, if the patient just kind of tries to kind of arch their back so that they get a little bit of lumbar extension, their symptoms are going to increase. But if you activate the core and try and move at least towards neutral, maybe even to lumbar flexion, their symptoms will go away. So being in a true supine position with the hips and knees extended will increase the symptoms as a result, just because of the increase in relative stiffness of the hip flexors, moving the spine into extension. Even if it's just slight, will probably increase their symptoms. So you want to work towards trying to be able to tolerate that position of true supine without any pain. With hip and knee flexion, you may note that there's an anterior pelvic tilt and lumbar extension, which increases the symptoms, and this is just due to iliopsoas activity, which can extend the lumbar spine as it flexes the hip. So you may need to have the patient perform this passively, or at least active assisted to begin. And then shoulder flexion, just as in lumbar extension rotation syndrome, will cause lumbar extension and cause some pain. So here's a picture. If you look closely right here, as you know, I'm flexing my hip, you can see a little bit of an arch right in there, versus with core activation, so the corrected version, you're not seeing much of that lumbar motion at all. And if you're just doing this more for testing purposes, remember, you can passively stabilize here at the pelvis while the patient repeats and see if it reduces or eliminates the symptoms. And then here's a video of shoulder flexion. So you can see really arching there. And stabilizing, maybe a tiny bit of arching still going on because I have a little bit of extension rotation syndrome. But I'll play that one more time so you can see it again. Again, exaggerating here, you really see the rib cage come up and the lumbar spine extend. And then if you stabilize with the core, you should see a lot less movement and decrease in symptoms. All right, so now you get the patient in quadruped. Again, this position probably will be pretty comfortable for them. But if they rock into forward position, lumbar spine will probably extend, hip extend, and they'll have an increase in discomfort. If they rock backwards, flexion of the lumbar spine, it will decrease the symptoms. And if you just have them in quadruped and kind of, do the cat-camel position, so flexion, extension, lumbar spine, you'll have a decrease and increase in symptoms respectively. So if you have the patient just standing against the wall, so kind of using that for support, and you have them flatten their back, or at least move to neutral, that will decrease their pain compared to natural standing. It's almost like giving some support to the back, so it's not sitting in that posterior sheared and extended position. So this is just what it looks like. You have the patient back into the wall and flatten their back. Their arms don't have to be out like that. I had it so I could make sure I could show you guys what it looked like. But you could do different exercises in this position, whether it be lumbar or shoulder flexion, to work on lat length while maintaining that posterior pelvic tilt. Now in gait, you'll probably see the exact same presentation as what I showed you before for extension rotation syndrome. So if you want to view that again, go back to the previous video. Lumbar rotation syndrome. So symptoms are typically unilateral or greater on one side, and the symptoms are increased with rotation of the lumbar spine. The associated diagnoses are degenerative disc disease, spondylolisthesis, osteoarthritis, spinal instability, and facet syndrome. So the associated signs that the patient may present with are any activities that require repeated rotational movements. Again, golf, tennis, sitting at your desk and rotating through your trunk, may be sitting on one foot, crossing their legs, leaning to one side repeatedly, may have asymmetrical like T-band length or a leg length discrepancy. So in standing, again, you may note that paraspinal and rotation mobility have, so paraspinal palpation, as far as the hypertonicity goes, and then rotation mobility may have an asymmetry, kind of similar to our extension rotation syndrome. And then the symptoms might be present or increased with side bending. So you may note that there's an asymmetry with the side bend motion, but also that in one direction you have like a true curve in the lumbar spine if you're looking at the spinous process, versus the other there's like almost a hinge point where it's like a line and then a line, or like a line and then a curve above it, where the motion is occurring. And I've got an okay example of that on the next slide. In full flexion, It's not typically painful, but you may see that at the end point of flexion that the lumbar spine is rotated one side. And when they rotate or come back from flexion into standing, if the patient rotates, it may cause some pain. And single limb stance, you may see that lateral trunk flexion or pelvic drop like we had before as well. So here you can see a pretty smooth curve in the spine. And then here you might have one point here that is hypomobile. And so the motion is like a straight line right above. All right. So I came in and I blocked that motion with my hand, and the the curve somewhat smoothened out. It's still present a little bit there, but what we're trying to do is basically prevent or force motion to come from all those joints by putting that block in there, and then that tells us that there's a point which may benefit from some manual therapy to try and improve the mobility. And you could do that for any time that you're looking at lumbar side bend. So in sitting, if you have the patient extend their knee, you'll probably see the lumbar pelvic region rotate, and that may increase some symptoms. So if you stabilize the lumbar spine and have them repeat, the symptoms will go away. Now, if you have the patient kind of extend in a bit when they're in sitting, you may see that a few lumbar segments actually rotate while doing that. Now, in quadruped, you'll see an asymmetry in the lumbar spine. So again, some of the vertebrae are either rotated or there's just that hypertonicity there. And if you rock backwards, you'll see an increase in that asymmetry, but it may decrease their symptoms. And if you have the patient flex one of their shoulders, you'll see some rotation in the lumbar spine as well. All right. In supine, if they flex their hip or knee, you'll probably see the pelvis rotate. Again, that should be an asymmetrical presentation. If they are performing bent knee fallout, you'll have an increase in symptoms, and you'll see pelvic rotation during the initial 50% of the motion on the involved side. Stabilize and repeat to see if it eliminates their symptoms. During an autonomous test, you'll probably notice an asymmetry as far as that goes, or at least an increase in the anterior pelvic tilt on one side compared to the other. The position of supine may be painful because maybe it's causing an increase of rotation on one side. And then rolling may be painful if they're leading with either their upper body or lower body. So that's where we want to teach log rolling. So again, really exaggerated it in this video here. So this is more segmental rolling that I start with here. But you can see all the rotation shear that's having to go in the lumbar spine there. And then if you go into log rolling, even that wasn't exactly perfect, but it takes some of the rotation strain off the lumbar spine, makes it much more tolerable. And that's very important because you'll have a lot of patients say how getting out of bed, or you'll just see when they're in your clinic, they have a really hard time with transfers. So teaching them log rolling and proper transfers is essential. Now, if you get them in sideline, that position may be painful. But if you can put that towel roll under their waist again, it may eliminate their symptoms. You'll notice that same pelvic rotation, lumbar rotation during a clamshell, so correct that. And same exact presentation with lateral pelvic tilt and hip adduction, abduction. Oh, and I've had that link to rotation. That's important because with hip adduction and abduction occurring, remember, you may get some side bend of the lumbar spine, and side bend is linked through coupling to rotation of the lumbar spine. That's why it may cause some symptoms. All right, so here are some pictures of hip abduction and adduction. So here up top, You can see right here how there's like a side bend, and use my belt almost as your guideline. How it's forcing the lumbar spine to almost cause a contralateral side bend with the adduction. Now, if I maintain the core position and a little bit more towards neutral, you don't see as much of that side bend occurring. Abduction is a little easier to spot. So as you perform abduction, you can see the hip hiking and the ipsilateral side bend. And then when corrected, so stabilization of the pelvis, whether it be passive through the patient or yourself, or just through core contraction and isolated hip motion, symptoms should go away. All right, and then in prone, you may see during knee flexion that there's asymmetrical pelvic rotation, as we've shown before. You may see some hip flexion with it as well. And then during hip extension, you may see the same presentation of lumbar extension or rotation on one side greater than the other. And with hip rotation, again, could be either external or internal. You'll notice early pelvic rotation, and you want to stabilize and correct for all three of these. And so here's a picture showing, again, internal. Here is the proper way of doing it, where you don't see the lumbar spine moving. And then here, you'll see the compensation occurring. So we're moving on to rotation flexion syndrome. So what I hope you've gathered so far is that you can see there's a lot of redundancy for all these tests. So in reality, you just need to perform all these tests and pick up what things are positive, and that'll kind of move you into one category versus the other. So anything that if a patient repeatedly has rotation type symptom or movements that are causing their symptoms and decrease with stabilization, you know that it should fit into one of the categories: rotation, flexion, or extension, all those with rotation. And if depending on the other findings, that's what kind of moves you more towards one versus the other. So if it's only with rotation activities, then it's probably just rotation syndrome. But if it's flexion and rotation tests are positive, then it's probably rotation flexion, or same thing with rotation extension. If all those are positive, then that's probably that. And not every single thing has to be positive, but you want to cluster those findings. Again, I hope that makes sense. If you have any questions about it, please feel free to contact me. All right, so lumbar rotation flexion syndrome. The symptoms are often unilateral or greater on one side, and symptoms are present or increased with sitting to standing movements. All right. The associated diagnoses are herniated disc, degenerative disc disease, osteoarthritis, and spinal instability. The associated signs are job or fitness activities require repeated unilateral limb movements or trunk rotation, and apparent leg discrepancy in standing, a habit of rotating the trunk and not the entire body while sitting, a habit of sitting on one foot or legs crossed, asymmetrical IT band length, and during prone knee flexion, guess what? Again, you're going to notice pelvic rotation. All right, in standing, you'll have your patient probably present with increased symptoms into flexion, and you may see an asymmetry in regards to that lumbar rotation occur as well if you're looking at the lumbar paraspinals. The symptoms are decreased now if you educate them on hip hinging, which is an important component for these patients. All right. So when you teach them that motion only comes from the hip, they're going to feel better. And then you'll reintroduce flexion in the future. With side bending, you may see that it's asymmetrical, and you may have that hinge point on one side causing some pain. So block it to ensure that you can make that smooth curve in the spine and decrease the symptoms as well. The position of standing is less painful than sitting. Reason being is because it's more of an extended position. The rotation mobility is probably asymmetrical because the patient's presenting with a rotation flexion syndrome. It's probably more painful one side than the other. And then in single limb stance, you'll probably see that rotation of the lumbopelvic region as well. Now in supine, During the bent knee fallout, you're going to see the same pelvic rotation as before. So stabilize that, see if you can eliminate the symptoms. And then they should be able to lie supine without an increase in symptoms. Like that'll feel fine, and it will probably actually feel good to them. And if you put a towel under their spine, like roll up a lumbar roll and put it under there, it'll probably decrease their symptoms even more. Because again, you're encouraging extension while their spine has a direct direction of susceptible motion into flexion and rotation. If they flex their hip, you'll probably see that they have a preferential pelvic rotation, so stabilize and correct. And then they probably have a unilateral TFL stiffness and pelvic rotation during the Thomas test. In sideline, the position probably will be painful again because of the rotation component, but decrease with a towel under the waist. And during a clamshell, you'll probably notice the whole trunk or lumbar pelvic region rotating during a clamshell. So stabilize. And during hip adduction and abduction, you'll have the relative pelvic tilting, which can cause some pain. And then once you get the patient in prone, as they flex their knee, because of the rotation components, you're still going to see the lumbopelvic rotation aspect. And if you have the patient perform hip rotation, you're going to see pelvic rotation with that as well. But the position of prone itself will probably decrease symptoms, again, because it's associated with lumbar extension. Now in quadruped, they'll probably sit in that position in a slight lumbar flexed position. So you may see an asymmetry as far as the lumbar paraspinals go if you're looking at it from the posterior or I guess inferior or superior aspect. But if you move them into extension, it will reduce their pain. So with rocking backward, it's going to be painful for them, and you'll see a significant preferable motion of lumbar flexion compared to hip flexion, and you'll see some lumbar rotation as well. Same thing with during the arm lift, you'll see that lumbar flexion or rotation. Now in the sitting, symptoms of course will be increased when sitting in lumbar flexion compared to if you had corrected into extension. So having proper posture, again, essential for these patients. And if you have them extend their knee, they'll exhibit some pelvic rotation, which is probably painful. So correct. So this is how they'll probably present. They'll even more so, probably the thigh will be a little more posterior, so like a little bit of diagonal there. But you'll see that lumbar spine and flexion. That's how they'll prefer to get into that position. But if you correct it, they'll feel better. So encourage a little bit of movement towards neutral or even lumbar extension. And then here's some pictures here. So first, as you extend the knee, you can see how all that flexion and rotation is occurring right there. Versus if you get into neutral position and extend the knee, it's not going to cause as much of a symptom. All right, lumbar flexion syndrome. Last one here. So the symptoms are increased with positions or movements into flexion and are decreased with positions that decrease lumbar flexion. So associated diagnosis, herniated disc, lumbosacral strain, lumbago, and degenerative disc disease. All right, some associated signs are you may note a loss of a lumbar curve. So they may have a sway back or flat back. And they may have shortened length of the glute max or hamstring and rectus abdominis. Long paraspinal muscles as well, just because they're in that flexed position. Now in standing, you may notice that during lumbar flexion, you're going to see greater motion from the lumbar spine than the hips. Now, if it may increase their symptoms as well. If you correct it and get them to preferably move the hips instead of their lumbar spine, the symptoms should decrease. However, if they have radicular symptoms, so it may increase their symptoms still, and that's due to just the neural tension component. And then the position itself of standing decreases symptoms, again, because it's associated with lumbar extension. In quadruped, the preferred position will be flexion for them, but if you move them into extension, it will decrease their pain. And then rocking backwards increases their symptoms, and you'll see that more motion comes from their spine. So here we go, lumbar flexion with poor hip motion, and then it gets corrected. So you'll see all preferably lumbar spine. You get some hip at the end there, but a lot of flexion occurring, even a lot of thoracic. And then, so a little bit of hip hinge there, and then you get some lumbar flexion at the end. For training purposes, you probably want to start with just the hip hinge. All right, and then you're going to go with quad rock back, exhibiting excessive lumbar flexion, and then corrected. Oh, come on. All right. So watch the lumbar spine, a lot of motion coming from there. Come back up, and then we're going to drop down into more neutral, maintain that, and as soon as motion occurs at the lumbar spine, that's when we stop and come back forward. All right. In sitting, the patient is going to prefer to sit in a flexed position, like most of us, right? But if you put them in more of a neutral or extended position, it will decrease their symptoms. During knee extension, you may notice that the lumbar spine flexes and increases their symptoms. So correct that. Stabilize the spine into lumbar extension or neutral, and have them repeat it. The position of prone may decrease their symptoms, and you occasionally will see a posterior pelvic tilt during knee flexion, and that would be due to hamstring activity, but that presentation is uncommon. Notice we don't have a lot of those rotation tests because this test itself doesn't have rotation involved with it, or extension. Or these tests, don't have rotation or extension involved with the presentation. Now, sitting in flexion versus extension, pretty obvious, okay? You're gonna want your patient to regularly sit more like this throughout the day, using a back support, of course. Once you get the patient into supine, all right, the symptoms may increase with the final phase of hip flexion. The reason being is because they're moving into lumbar flexion as well, probably. The lumbar spine is probably going to flex before they even get to 120 degrees of hip flexion. They'll be able to lie with their hips and knees extended without any increase in symptoms. It'll probably feel good to them just because, again, they're in an extended position. And if you put that towel underneath their lumbar spine, they'll feel better because it's encouraging extension. The double knees to chest will increase their symptoms as the lumbar spine flexes, of course. So here's marching, or supine hip knee flexion is what Sarman likes to call it, which I'll first exhibit with lumbar flexion and then with correction. So if you watch, you can really see my back flattened out down there, and then I'm gonna extend the lumbar spine a bit, and you see no real motion is occurring in the lumbar spine during that second one. So watch again as the lumbar spine, you get a lot of movement right here, and then I'm going to move to extension and isolate. There you go. All right, I think, yeah. All right, so now on to treatment. And I'm just going to talk more about the general concepts of treatment as opposed to going through each and every example, because it's actually not that difficult to understand. So there are two significant components with treating movement impairment syndromes. You want to minimize the stresses that are contributing to the dysfunction and then focus on core stabilization. So identify the repetitive motions that the patient is completing throughout the day. Repetitive motions and prolonged postures. I didn't put that in there. Completing throughout the day that may contribute to the symptoms, and teach them how to modify. So, for example, if they're sitting all day in that flexed position and they present with lumbar flexion syndrome, teach them how to use a towel roll and properly use their back support so that they're trying to stay out of that flexed position. Maybe they have to repeatedly pick stuff off the floor. We'll teach them how to hip hinge or maybe do the golfer's pickup, or squat down with minimizing stress on the lumbar spine each time that they do that. If it's rotation, make sure you teach them how to rotate the whole body at each time and not just do segmental. If they're sitting at a desk, you may want to teach them how to rotate their whole chair or move everything closer to one position so they don't have to rotate as far. It's not that we want to eliminate the ability to rotate, but during these initial phases, we're trying to minimize the stresses so that we can get the symptoms under control, and then you can reintroduce them with proper mechanics, because the focus is on retraining how people move. All right, and then the focus on the exercises for each movement impairment syndrome is dependent on the direction of susceptible motion. The overall goal for the lumbar spine is to stabilize the spine while the challenging motion is completed with various loads based on position, intensity, speed, etc. One method of exercise selection can be to use the tests as exercises, but focusing on stability. So, as I had in pretty much all those videos, you saw me perform the test poorly and then correctly. Those can become your exercises right there, because you are challenging the direction of susceptible motion with the actual active motion. And so you're just going to have them activate their core and stabilize it and do however many repetitions to make sure that they're basically learning how to dissociate hip from lumbar motion or whichever body part. And you want them to, it's basically trying to retrain how they move. You can also make sure to improve the mobility of joints that present as relatively stiff. So this is where maybe your manipulation can occur. Maybe this is where you do some soft tissue technique to decrease the hypertonicity in a specific area. Whatever you prefer, but the biggest focus in Sawerman's mind should be on core stabilization, because you want to increase passive tensile resistance on the hypermobile area so that movement will come equally from each region. Now, we want symmetrical mobility and strength and recruitment. So the reason for symmetry is without it, you become at risk for any kind of rotation dysfunction. So really focus on making people symmetrical. Now, there are exceptions to the case. For example, think about your baseball player. They're not going to have symmetrical shoulder mobility in each direction. However, you're going to work to provide some stability to at least minimize the extremes of it. Now, as I was saying before, it's more important to strengthen what is weak than to stretch what is short or tight. All right. And the reason is the increase in passive tensile structures is used to decrease the difference in relative flexibility. So in our muscles, we have these passive tensile structures that are the reason why some muscles may appear stiff, not truly adaptively shortened. So as you move into hip extension during the Thomas test, you'll see the lumbar spine anterior pelvic tilt. But if you stabilize the pelvis, they can move into full hip extension. And it's just because the hip flexor is more stiff. You can stretch that muscle all you want, but probably you're not going to change that movement presentation there. So you need to focus on increasing the passive tensile structures in the lumbar spine and the core to try and match that. And the way you do that is actually by just increasing the strength of that region in order to increase those passive tensile structures. Now you can shorten the muscles that are lengthened. That is a help as well. So as I was saying much earlier in the upper trap scapula phenomenon, you want to provide support to the lengthened muscle so that it's not being strained into a weakened activity. Now, initially, we want to focus on how each motion is performed, not necessarily repetitions or resistance. So we want them to be able to dissociate hip from lumbar motion. Once they get that, that's when you start doing some prolonged holds with fewer repetitions. That is for the focus of sustained postures, because that's probably going to be the starting point for most people. And you want them to perform that slowly so they learn how to properly activate and control each muscle. From there, you can increase the repetitions and then increase the resistance, and then increase the hold times, but do that all in a gradual manner to make sure that they learn and retain each aspect of it. You should also notice that just slapping a TheraBand on might change the exercise completely. For example, say you're having them perform a supine bent knee fallout, and without any TheraBand, they're performing the exercise, and they get control of it without any resistance. But then you slap it on around their knees. Well, instead of being an eccentric hip adductor motion, all of a sudden it's a concentric hip external rotation abduction motion. So make sure you're thinking about that sort of concept. You can't just automatically throw a TheraBand on and it's going to work the same way. Once they've mastered how to move and perform these isolated motions, whether it's on the table, in standing, in sitting, that's when you want to make things a little more dynamic and probably functional. So whether it's like with a crate lift, a golf swing, vacuuming, but you want to start with the lower level stuff and move towards the higher level activities that they'll present with, which is going to be probably what they'll appreciate the most, because they'll see it translate into their daily life. All right, and that is actually it. So in general, as far as treatment goes, once you've identified the direction of susceptible motion, make sure you teach your patients how to dissociate in this case, the hip motion from the lumbar spine. And you want to begin with core stabilization. And you can use your manual techniques to work on any actual like joint restrictions or stiff regions that present as well. But the focus should be core stabilization. If you have any questions at all, please feel free to contact me. I hope this helps bring together some of the stuff that we talked about at the last Optum course. And for all of our other listeners, if you have some questions about Optum in general or this course, feel free to contact myself. Be happy to help, and hope you guys enjoy the rest of your day.